Thank you, Dr. Vishali, for giving this opportunity. Good morning, everybody. So, ICG is at this junction whether to hire it or to fire it. But it came in 1971. People did use ICG for hemangioma cases actually. So, what it takes cares is what it tells us more than FFA is it images the choroidal vasculature, which we miss on fluorescein angiography because of the various reasons there, because the dye comes there in the retinal vasculature and that area is hidden behind it. And it could also tell you that whether there are melanin there, xanthophyll there, the opacity is there, which will not allow you the imaging, and it would give you the clear idea with the ICG. So this is very interesting thing written about ICG in an article, and of course in the Ryan's book of retina, that even in the era of anti-VEGFs, it still is extremely useful in clinical practice actually. The role of ICG started, it was very popular in 1990s, and these were the indications at that time because the people were doing lots of these, looking for these membranes specifically, and they're treating them. So it was used for ARMDs, all the conditions which were associated with TNVs. So it was very popular doing ICG at that time. And of course it was being used for the serous chorioretinopathies and the choroidal tumors. So anything which is the disease which is pathology is suspected with choroidal, ICG was being done. So why it has lost its charm? Why the people are not doing it? Because it's a difficult tool to interpret, the first thing is, and there is a lot of improvement there in the imaging. The people have come with now OCT there, and lots of new things have come up. So the indications of ICG have gone down, and much to add to that is the management of our now the AMD or the CNV, because we don't need to clearly show where the CNV, whether it's occult or classic. We are going for anti-VEGF, so people are not doing ICG, that many ICGs actually, but it still has a role. And the indications are, what you say is it has a role in the PCV, because it is very relevant in our population. You have to remember the ICG's role in our world. The Asia is increasing in patients of IPCB, because we see more IPCB in our population than in the West actually. So it has a role here. Of course, the delineating choroidal hemangiomas, sometimes in the typical cases or where you want to treat them. And of course, the patient with a serous chorioretinopathy, where you want to treat them with Visiodine PDT. And of course, the white dot syndrome, where you want to see the exact pathology, where FFA is inconclusive or where the atypical features are there. As I've already said, use of ICG is going to be much more in Asian countries than in the West, because it's more frequent here. It will be used for diagnosis, prognostic management, and prognosis. Of course, the treatment part is really, when people have not decided whether to go ahead with, the anti-VEGF or the PDT. This is one such case where you see the subretinal bleed there, and you see this typical lesion there. And when you perform ICG in these patients, and this is beautifully shown with the FFA there and the ICG there, and you can see clearly the amount of the lesions there, the classic polypoidal lesions seen on the ICG angiography, and this is FFA angiography, are much better than the FFA actually. This is how the advantage of ICG is. Despite the presence of this kind of a bleed here, it is able to pick up such beautiful lesions, which will clearly demonstrate that this is not the AMD, the classic AMD we are dealing with. We are dealing with the IPCB there, which will require more injections, or which will require some other therapy there. So this is how the patients look like, and this is how the late phase of ICG, IPCB looks like. The next indication, what I say, is choroidal hemangioma. Of course, it was the first one to be used, where the ICG was used, and it clearly differentiated from the tumors and amelanotic melanomas. What classically, hemangioma, ICG is required where you want to treat these patients, with the PDT or with the TTT there, because it clearly demarcates the boundaries of the hemangioma, which are not clearly seen with the FFA. So this is how, there's another example of a patient who underwent combined FFA and ICG. You can see the boundaries, which were, of course, the choroid changes will be much clearly seen on ICG, but these changes are very, very classic, and they are very well delineated than angiography. If you see that in the late phases, the angiography is confusing us with it is not clearly telling where to apply the laser, where to do this. But ICG is clearly showing the boundaries there actually. Again, ICSE, of course, you have chronic variety and the acute variety, and it clearly tells you that it is, because it has shown that it is of choroidal etiology, the ICSE, and then differentiate from the IPCV. EDIOCT will tell you just the thickened choroid, but exactly what is happening behind, it will be shown by the ICG. And if you want to treat these eyes, you need, with Visidyne PDT, you need ICG. But extrafoveal and the other kind of lesions can be treated with FFA also. Like in this case, the FFA shows you, but it confuses you in the end, the kind of a lesion, what kind of lesion is there, and what is this exact size. But ICG will give you the hot spot, and which remains very well delineated in the end, and clearly shows which is the area to target when you are treating these patients. Of course, inflammatory white spot disease, because there is something happening in the choroid, the choriocapillaropathies or the stromal disease. So they classically are seen better with the ICG. So these are the white dot syndromes which you can manage by with the ICG. The advantage it gives is, you have to remember that ICG will show you more areas of involvement, and it will, the lesions, the ICG lesions will fade much later than the clinical lesions and much later than the FFA lesions. So if you are following these patients, you can do ICG, but like sir said, now the better tools are available. So rather than doing ICG, the people are doing fundus autofluorescence to show that lesions are healed or not. So this is one such, patient who underwent combined FFA and ICG, and you can see the number of spots are seen much better with the ICG than with the FFA. This was the tool which was used, and it shows that the extent of the lesion and the amount of the lesion actually. And this is how it looks like. You see a hypo, and which will remain hypo in the late stages also, and FFA shows typical hypo to hyper lesions. To conclude my talk there, it is not wrong to say that the indications of ICG are now what are the indications for your Visidyne PDT. So say it IPCV or hemangioma or ICSE, but it still has some role in the patients where of white dot syndrome or inflammatory diseases where you want to look for the atypical cases. Thank you so much for listening.